Hello everyone, hope you all are good. Welcome to Make you again. So, as we discussed, we'll start Krok 2 therapy discussion, and this is our second video in series and first video discussion. So, uh, first we need to know how should I approach the questions. So, this is the base, okay, of Krok 2 medicine. So, we can do in different ways. So, we can clear all the bases and then approach the question. This is one way, and this is the best way, I think. But as we have less time, so we cannot do that now. So, what we can do is we can check some keywords and also some related topics regarding this. So we'll cover one question and regarding this related all the questions we will discuss two, and we'll try to exclude the other options too. Okay, so let's start. So first question is, a 47-year-old woman complains of having paroxysmal headache for 5 years. The pain is one-sided. Okay, intense localized in frontal region of head accompanied by nausea and stomach discomfort, begins one of a sudden. Onset is usually preceded by vision reduction. Anamnesis gives evidence of periodical epirise, but at the moment the woman doesn't take any medicines. In between the onsets of headache, her state is satisfactory, objectively high calorie diet, body weight index is 29, AP 170 by 95, neurologic state has no peculiarities. What is the most probable diagnosis? So we'll first try to approach the question. Okay, so first we will try to find what they are trying to say. So we will try to find the keywords. So here we have seen that there is paroxysmal headaches. First hint is here. Then the pain is one-sided, localized in the frontal region of head, accompanied by nausea. Onset is usually preceded by vision reduction. So we have a vision reduction, right? And there is no neurologic state, has no peculiarities. So these are the words we needed to find. Okay, so there is like 5 to 6 sentences. You don't need all the information, you need some words to make the diagnosis. So first one is paroxysmal headache, one-sided, localized in frontal region of head, nausea, vision. Okay, so first we need to exclude some answers. So if we don't have any neurologic state like any focal deficit, so we can easily exclude some answers. Like in migraine, do you have any neurogenic or neurologic state or focal deficit migraine? It may be or may not. Okay, in subdural hematoma, we will have some deficit, focal deficit. So this can't be the answer. Epilepsy, there will be history of seizures. Benign intracranial hypertensive encephalopathy, again we will have focal deficit. And intracranial hypertension, there will be some specific sign like papilledema or something else. So we don't have anything like that. Okay, so this also can't be the answer. So here, with excluding only, we can know that our answer is migraine. But this question, like they will not give this question like this, they can twist it and for that we need to know the types of headache, right? So in types of headache, how many types of headache do you know? First one, as we read, it is migraine. Second, there is tension headache, and third one is cluster. So we are discussing headaches here, okay? Headaches, headaches keeps headaches, and there is one more sinus headache you can say, but it is least important. So main we will discuss these three. Okay. So in migraine, what we can see, what is the specification of migraine? It is most commonly unilateral. Okay. So one side will be affected, not the both side of it. We will see aura. What is meant by aura? Aura is like you will see something black in front of your eyes with some starry appearance. Okay, we all feel that, I think. Then we will have photophobia. We will have phonophobia. We can have, sorry, phonophobia. It can triggered by weather change. So, like, how it will look? Sorry for my drawing. Okay, if this is your face, so the headache will affect one side of the head. Okay, like this. And one more thing, it is pulsating. Pulsating, you can say throbbing. So these are the words you need to find where you are suspecting migraine. Okay. Then tension headache. There is one word. Okay, it is band like. So if you see band like headache, you go for tension. Here we can see our happy face, not happy face actually. So tension headache will a band like headache, okay, like this. So your forehead, it will be over your forehead, band like. The third one is cluster, the most dangerous one. Okay, in cluster headache, it actually we can see it by like our drawing here is sad face. So in this headache, the orbital region, this severe pain in the orbital region, severe, okay, very severe. So very severe pain in orbital region. So these three, if you do these three, your headaches are already covered. Okay. So you need to find the words. You need to know the location, and your headache is complete. So any question from headache, I think you can do. For your knowledge, we can, if you Want to know about the sinus one? Sinus one, you know the sinuses. So this. So the headache will cover these areas. Okay. So it will be your sinus headache. So now we can see it is one-sided, right? In the frontal region. Nausea, yes, migraine are do associated with nausea. We have photophobia, no neurological deficit. So our first answer is migraine. Second one. A 7-year-old boy suddenly felt pain in his right knee. It became edematic. The day before he took part in a cross-country race. Family anamnesis has no data about hemophilia and bleeding sickness. Objectively, blood temperature 37, knee is painful, hot to touch, edematic with local tissue tension over it. Blood count hemoglobin 123, leukocyte 5.6, thrombocyte 354, prothrombin time 12, which is normally 10 to 15, so it is in normal range. Partially activated thromboplastin time 72, weight is increased, right? So it is APTT increased. Hemorrhage time is normal, so bleeding time is normal. Factor 8 is 5% of the normal. What is the probable? Again, we need to find the keywords, right? Or the important words. So here is a boy who suddenly felt pain in his right knee. Right knee become edematic. Knee is painful, hot to touch, and edematic too, with local tissue tension over it. Blood count normal, leukocyte normal, thrombocyte normal also, prothrombin time normal, partially activated like APTT is increased. Factor 8 is only 5% of normal. So for this you need to know all the bleeding disorders, right? So we can exclude something here. Can we exclude? Yes, I think. As here you can see, as here you can see, thrombocytes is normal. Okay, thrombocyte normal. Thrombocyte is 150 to 450, so it is 350. It is normal. So thrombocytopenia can't be our answer. Okay. Then Sconlen-Henoch disease or Sconlen-Henoch purpura. For that we have a classical triad, right? So for this we will have purpuritic rash, purpuric rash. We will have abdominal pain and we will have joint pain. So here we cannot see any rash, we cannot see any abdominal pain, we only see joint pain. So this can't be our answer. Now we have three: hemophilia A, hemophilia B, and vitamin K deficiency. For that, again, what do we need to know? We need to know the disease, all the disease, right? All the bleeding disease. So now what we are discussing? We are discussing the bleeding disorder. Bleeding disorder. Here we have First one is hemophilia group. Hemophilia group. Then second we have von Willebrand disease, and the third one is vitamin K deficiency. So among them, if we try to distinguish between them, okay, so in vitamin K deficiency, we'll have increased prothrombin time. In von Willebrand disease, we'll have increased bleeding time, and in hemophilia, we'll have increased PTT or APTT. So now we back to our question. We see its prothrombin time, it's normal. So if prothrombin time is normal, vitamin K deficiency can't be our answer. So vitamin K deficiency can't be our answer. Von Willebrand disease bleeding time is normal. Bleeding time is normal. We don't have von Willebrand disease. If we have also, that can't be our answer. So now we left with hemophilia A and B. So now do like this. So we'll talk about hemophilia now. In hemophilia, we have hemophilia A, hemophilia B, and hemophilia C. Also we have parahemophilia. Now how to differentiate between them. So there are some factors, you know, right? Intrinsic, extrinsic factors. So in hemophilia A, we'll have deficiency of factor 8. In hemophilia B, we have deficiency of factor 9. In hemophilia C, we will have deficiency of factor 11. And in parahemophilia, we have 5. Also, we can just add a little bit of information for your knowledge. It will help you in Krok and in FMG too. So we can also discuss the inheritance, right? So in hemophilia A, it is X-linked recessive. In hemophilia B, it is X-linked recessive. Hemophilia C is autosomal recessive. Parahemophilia is also autosomal recessive. So as we can see, so hemophilia A, it's factor 8, hemophilia B, factor 9, hemophilia C, factor 11. Now let's get back to our question. We have factor 8, which is only 5% of normal, so deficiency of factor 8. So cannot be hemophilia B as it is factor 9. So this is factor 8. Also this is PT is increased here. Okay. So our answer is, you can see our answer is hemophilia A here. Okay. So we need to approach our questions like this. So as we said that we'll keep our questions like 15-20 minutes we have completed our 20 minutes quota. I think only two questions are discussed. So thank you for watching these videos. See you in next video. Bye bye.